So welcome this evening to the very important topic of the moment, which is the menopause. Personally, I believe the menopause is not being given enough platform as it should for discussion, for information sharing, for empowering women to make informed decisions. So this evening, we hope that through our expert speakers, and I'm happy that we have our speakers are from diverse backgrounds and they'll be able to cover as much as possible around the topic of the menopause. And I hope you are going to be able to get enough information actually to make a difference to perception, to management, to care, and impressions about the menopause going forward. Our first speaker today is Chiza Wesker, all the way from Australia. She's a nutritionist and skin consultant. Right, and that's why I always love them to introduce themselves so that they can do justice to what they do rather than me just blabbing out a biography. Also, just to remind you that it's an interactive webinar, so please feel free to input your comments, and after each presentation, we're going to have question and answer session. Because of the time differences, we'll get on with the first presentation. We have polls for you to whet your appetite, to learn and share. And then we have, of course, the survey later. Before I hand over to Chiza, I just want to say thank you to you all. You are a very important group because exactly 5 years today, 2016, we had our first Zenith Global Health meeting and healthcare awards. So I hope, especially the people on this webinar, will stay with us for the next 5 years, and together we make a difference, make an impact, to healthcare globally. Thank you. Chiza, over to you.
Well, it's your evening, it's my morning. I'm in Australia.
That's true.
It's 5 a.m. here. I know it's your evening, so good evening to all of you. Mary, I want to begin by saying thank you very much for this amazing opportunity to be here presenting with this group of esteemed and obviously very qualified women that we have here today. My background is a little bit different to the rest of the panel. As Mary said, I'm a nutritionist. I'm also a skin expert, and I'm coming at the menopause from maybe a little bit of a different angle. I actually use nutrition very successfully to manage menopausal symptoms, and I want to share a little bit with you this evening. So when we describe the menopause, we talk about it being the cessation of the menstrual periods due to loss of ovarian function. And usually it is a period of 12 months after the last period that qualifies one as being in the menopause. Due to the aging general population, both the proportion of women who are menopausal and the total population of menopausal women have increased. Everyone goes through the menopause at one stage, but symptoms vary from woman to woman. Despite having the greatest impact on the health of a woman, the menopause is still one of the most neglected areas of research. And I really feel that women have been done an injustice in this department. While every menopausal woman has falling levels of estrogen, not every woman going through the menopause experiences the debilitating symptoms such as hot flashes or flushes, lack of mood or low mood, lack of energy. So people experience the menopause very differently, and I've seen it myself. And so the question that I ask is, could the fact that women experience menopause differently, with some having no symptoms while others suffer quite terribly, could this be linked perhaps to such factors as gut health nutrition, perhaps even lifestyle. So my talk, as I mentioned, is a little bit different. I wanted to focus on gut health because this really is an emerging area that does need attention. When we talk about the gut, we are actually referring to the long tube or the digestive tract that starts at the mouth and ends at the back passage. In the gut, there are trillions of microbes made up of bacteria, fungus, yeast, archaea, viruses, and they all cohabit in this space. They are dotted all the way along the digestive tract, influenced by the pH of the areas. And these microbes collectively are responsible for health and also disease. These microbes collectively are called the gut microbiota. When we include their genetic material, we refer to the collective as the gut microbiome. But interestingly, there is a subset of the gut microbiota called the estrobolome. The estrobolome is made up of bacteria that actually regulate estrogen levels and affect circulating and excreted estrogen. And there is not a lot that is actually known or taught about the estrobolome, and yet it impacts the way women experience menopause significantly. A healthy gut produces adequate levels of an enzyme called beta-glucuronidase. And this beta-glucuronidase helps convert estrogen into their active forms. Unbound active estrogen is then able to bind to estrogen receptors and therefore be able to influence estrogen-dependent physiological processes. However, the more beta-glucuronidase is produced by these bacteria called the estrobolome, the more estrogen actually remains in circulation and is not excreted. And this is where we look at conditions associated with estrogen dominance. The estrobolome affects estrogen levels, which in turn can impact the inability to lose weight, cause libido or be associated with libido, cause PMS symptoms, mood fluctuations, and even estrogen-related cancers. When we look at the gut microbiota as a whole, it plays such an important function in our health. These microbes are responsible for the digestion of food and the absorption of both macro and micronutrients. These microbes in our gut are responsible for the production of neurotransmitters, hormones, amino acids, and very importantly, short-chain fatty acids. Short-chain fatty acids I'm going to touch on when I look at the kinds of foods that we should be eating. And the reason why these short-chain fatty acids are so important is that they allow for a systemic anti-inflammatory effect. These short-chain fatty acids that are produced from the breakdown of fiber, namely butyrate, propionate, and acetate, they also help fuel the cells that line the gut. 80 to 90% of our immune system is embedded in the gut lining. These microbes educate or influence our immune system. In a healthy individual, microbes that are considered to be beneficial keep the environment very hostile and so are able to control potentially pathogenic microbial numbers. Microbes play a key role in detoxification. They are involved in influencing gut motility. I see a lot of patients who go to the bathroom once a week or twice a week. I also see people who have chronic diarrhea. 95% of serotonin what we call the happy hormone is produced by these microbes in the gut. And so it really does astonish me that not many people know about how important the gut microbiota is. In a healthy person, it protects us from disease. These microbes also regulate hormones. As I mentioned before, this group of bacteria are very much dependent on our diet, what we eat. How do you know when the gut is unhealthy? Well, you would be experiencing gas, bloating, fluctuations between diarrhea and constipation, fluctuating weight, sensitivity to foods, feeling devitalized and fatigued, having certain skin conditions. We know that there's an association between poor gut health and inflammatory skin conditions, such as psoriasis, eczema, rosacea. And then having hormonal imbalances will also indicate that things are not quite right in the gut. So when we look at diet, I mentioned that diet is very important when it comes to gut health. We know that fiber is important for both microbial diversity and numbers. Eating a diet of processed inflammatory foods will actually reduce the diversity of the microbes in the gut. The Western diet is known to be associated with what we call gut dysbiosis, where the beneficial bacterial numbers go down and the potentially disease-causing numbers go up. And so the potentially disease-causing microbes are associated with ill health. When we look at menopause and the symptoms that we associate with menopause, such as hot flushes, inability to lose weight, mood swings, etc., we know that there are some definite triggers as far as food is concerned. Hot beverages can bring on a flush, spicy food can, alcohol can. And so when I, in clinic, am giving advice to women who come in to see me who are highly distressed, the first thing I do is I look at their diet. And then I give them a meal plan. And the meal plan is full of very colorful vegetables, lots of variety. We know that the gut microbiota needs to have diversity in color and in types of vegetables in order to be at their optimal. So Brussels sprouts, beetroot, red onion, broccoli, we basically say you are encouraged to eat the rainbow. The more colorful your fruit and vegetables are, the better your gut health is. But not only are we looking at introducing fresh fruit and vegetables, but we want to make sure that our fat sources are good sources. Oily fish is very rich in omega-3s. Omega-3s have a modulating effect on inflammation. So looking at good sources of fat. Protein consumption should be a palm size. We don't need more than a palm size. But we also need to be looking at introducing some fermented foods into the diet, because fermented foods actually are described as being probiotic. So they actually help the bacteria in the gut perform their functions optimally. So because my talk is both on gut health and skin health, I thought that I would also touch on the kinds of changes that I see in women going through the menopause. So we know that menopause actually is responsible for quite significant changes to the skin, which is the largest organ of the body. And this is as a result of declining hormone levels. We know that hormonal alterations during and after menopause result in changes to the skin's physiology and function in different ways. I have patients who come in to see me never having had a spot during their teenage years, but now have adult onset acne, and they're in their late 40s, going into their 50s. And that is as a result of the drop in estrogen levels, which then unmasks testosterone, and that is the association there. As estrogen levels decline, we find that skin atrophy occurs, because skin cells actually have receptors for estrogen. And so these falling levels of estrogen bring about a lack of turgor in the skin. And I actually have my ladies saying almost overnight, my skin started to wrinkle. The collagen loss was quite sudden, and it's very, very distressing for them. So collagen depletion, elastosis occurs because of this lowering level of estrogen and the effect that it has on protein synthesis. Collagen production slows down, but also the repair of collagen is also impacted. And then there's fat redistribution. So fat tends to disappear from the face, but almost redistribute itself along, sort of around the middle and the hips and the buttocks. But the face loses that fullness, the neck, the arms, the hands. And then there's also dryness, because what also happens with collagen depletion is that in the dermis, we have collagen and elastin structures. We also have glycosaminoglycans that keep the skin hydrated. And these sugars are impacted by collagen, by estrogen depletion. And so the skin becomes dry. We then also find that the capillary walls are affected by estrogen depletion. So we find that blood flow to transport oxygen and nutrients to the cells of the epidermis starts to slow down. Cell turnover in the epidermis also begins to become affected. And so the epidermis becomes very thin, paper thin. And then we also find that the pigment producing cell, the melanocyte, is also under the influence of estrogen. And so as estrogen depletes, we start to see hypopigmentation happening, where we find little patches of white areas where there is no pigment. And we also have issues with hyperpigmentation, where we have age spots, dark spots that we do not like the appearance of. So these changes happen because of the menopause. So what can we do? I think as the skin starts to age, we need to introduce what we call active skincare that has ingredients such as vitamin C in the form of ascorbic acid, because that stimulates collagen. Vitamin A is a rejuvenating ingredient. Retinol is what I'm really talking about. Then there are ingredients such as isoflavones, which is a soy-based estrogen. So it's a phytoestrogen that is topically applied to the skin that has some incredible remodeling properties, fades pigment, stimulates collagen, refines lines. And then there's DMAE, dimethylaminoethanol, and that is a tensor tightener, and it's used to firm the skin. And these ingredients are ingredients that you would find in a doctor's practice that has, maybe you're looking at a cosmetic physician, for example, that has actives in their practice. Dipanthenol or vitamin B5 is great both for hydration, but also to restore the hydrolipidic film on the skin's surface. So really providing hydration to that dry skin. Hyaluronic acid is another ingredient that is very hydrating and is topically applied. Moisturizers will then start to change. Normally, because the skin is so dry, a thick, rich, emollient moisturizer is usually what someone going through the menopause wants, because it's really going to feel nourishing. And then sun protection. I think with people of color, there is usually a reluctance to wear sunscreen by a lot of people of color, because with melanin, they don't think they need sunscreen. But sunscreen will keep your complexion even. There are a lot of very beautiful formulations on the market that do not leave a residue, a chalky residue on the skin. My preference is always for a physical sunscreen that sits on the skin's surface and reflects the rays off the skin. And you can find them in micronized forms where they don't leave any residue. You want to avoid skincare that is highly fragranced and that has alcohol in it, because they can trigger a flush. And then hot showers. If you look at lifestyle management, hot showers, hot baths, you want to avoid. I think it's important to get moving. So I get my ladies to commit to walking. We don't want vigorous exercise, which can actually bring on a hot flush in some people. So some non-strenuous exercise. Yoga is fantastic. But I think also to try and reduce stress levels, meditation, guided meditation. There are so many guided meditations that are, you know, available online for free, and maybe introducing some relaxation techniques. I think self-care is very important as well, because usually during the menopause, you know, sometimes women can have very heightened stress levels, maybe have some self-loathing. And so having something where you treat yourself, like a regular massage or a facial, I think is a good thing to introduce. And so I know that we don't have a lot of time, so I'm going to quickly wrap things up. I think in order to manage menopausal symptoms, introducing a diet that is a whole foods diet and putting aside those highly processed foods will definitely improve the symptoms. Starting to cook from scratch, and this is why I give my ladies a meal plan. It has a shopping list and they know exactly what to buy, and they all report back that they're sleeping better and their stress levels have reduced. And it's almost like just cooking from scratch has really given them a new lease of life. What I also do, because a lot of my women drink, and they come home, they open a bottle of wine. While they're cooking, they then sit down to another bottle of wine. And so that for a lot of them is a problem. So I give them, we have a few elixirs here in Australia. I'm sure that there'd be some in the UK. And these elixirs are concentrated dark berry drinks that I then add sparkling water to. And in clinic, I serve it in a champagne flute. So when I hand it to them and they taste it, they go, oh my gosh, this is nice. This actually feels like I'm having a drink. So a lot of them will then swap out their alcohol during the week and drink this beverage. And so they find that a lot of their symptoms improve because they're not drinking as much. And then taking the time to incorporate some exercise and make some lifestyle modifications. Add in the rejuvenating skincare, like I said. And I think by taking a holistic approach rather than just looking at medication to try and manage the symptoms will definitely result in better symptom management. And that's me. Take some time to smell the roses.
Oh, yes, please. Thank you so much, Isa. Thanks a lot. That was eye-opening. I was taking notes. Oh God, what have I done?
Do I now? I'll come out of sharing, shall I?
Yeah, okay.
I'll come out of
it's sharing. Me. Okay.
Okay, stop share.
Has anyone got questions? Yeah. So I'm looking for. Any questions? Okay, I'm just going to check here. Okay, interesting. Thank you. Yeah. Okay, thank you very much. Oh, Dr. Ineka has joined us. You're welcome.
Oh, there she is.
I hope you got some of those. Hello. Oh, there she is. Hello. You're welcome. Okay. Right. Before we go on, let's look at our first poll. And I'm going to give just like a minute or two so we can move on to the next speaker for us to put our answers in this. And then if any questions arise from it, we'll ask our panel. Okay. Okay, please take a few minutes, a minute or two to answer the questions in the poll. Wow. Okay, 3 questions though. Where's the third one? Okay. So the first question was, can a 20-year-old woman be menopausal? 50% said yes, 25 says no, 25 says not sure. How long after your last period can you be truly menopausal? 20% said 6 months, 100% said 12 months. Then the percentage, oh yeah. I mean, number 4 is like, we listened to Chisa, so we all got that right about the gut health. What percentage of menopausal women experience hot flushes? 50% said 75, 38 said 65, 50 said 38% said 65, 50 said 75%, and 13% said 50%. Okay, thank you. So do any of our speakers have contributions to the answers to the polls, especially where we have variations with the percentage?
Yeah, so up to 70% of the people can have like vasomotor symptoms. That's what we say. So it was including, like, it could be hot flushes, it could be migraine, and it could be, like palpitations. So overall, there could be like up to 70% of the females could have some of these symptoms, which we together put as like a vasomotor symptoms because of deficiency of estrogen.
Okay, thank you. I think the rest of it is quite straightforward, actually. Yeah. Okay, let's move on to our next speaker, Dr. Saba Al-Zabin of NAPTA Health.
Hi, Mary. Hi, everyone. It's good to be with you this evening. I should apologize. It's Guy Fawkes Day, and there are fireworks.
Oh, yeah.
So if you hear some banging outside, I promise you, no one's killing each other. It's just the fireworks.
Actually, I'm between 2 parks, so you probably hear some from this end as well.
Yeah. I'm going to share my screen if that's okay. Oh.
I think I'm the only one who doesn't have a presentation.
There's no requirement, I don't think. I mean,
yeah.
It just makes it easier for me.
And Chisa has said most of the stuff that I wanted to say.
We hear it again.
Emphasis.
Can you see my presentation?
Yes.
Yes.
Excellent. Okay, so good evening, everyone. My name is Saba Al-Zabin. I am the Chief Scientific Officer and co-founder of NAPTA Health. I come from a purely scientific background, a clinical scientist with a focus on immunology and oncology. I did my degree on autoimmune diseases, which is relatively relevant, something that Sheila touched upon, something that's quite relevant to menopausal women, because the majority of autoimmune disease actually onset post the menopause, and the majority of autoimmune diseases also affect women more than men. I then moved on to industry, where I worked to validate drugs for pharmaceutical companies in the area of inflammatory disease and cancer. Decided that the majority of healthcare is really unequal, and decided to improve on the evidence around health and well-being, specifically to try and improve on data diversity. The fact that, for example, women were excluded from clinical trials until 1994 is quite shocking. The fact that a lot of the blockbuster drugs that people normally take for granted have not been tested on women for various reasons. And also, now that we go into the age of genomics and personalized medicine, the fact that the majority of genome-wide association studies, essentially all of the genetic information that we understand that informs on how we should deal with diseases, how predisposed individuals are to diseases, how they respond to therapy, are based on data that is generated entirely about 80% or 85% of that data comes from individuals of Caucasian origin, and women actually do not represent the majority of that data set as well. So I moved into the area of women's health, and one of the many areas that we focus on all forms of areas where women and their hormones govern the way that they respond. The menopause is one of the large areas that we focus on. Again, I think everyone on the panel agrees that the reason why this has its own space is because there's an absolute need for us to understand more about the menopause and to be able to have ways to address it and understand how women actually suffer or don't suffer from it, and the fact that every woman is actually different. So I'm going to give you a little bit of evidence, but the focus of a very short focus, according to Mary's request, is to focus on hormone replacement therapy. So I like this quote. I was listening to a podcast, the Michelle Obama podcast, which recently started, and she had her favorite OBGYN on, and of the many things that she talked about, she was trying to explain to Michelle Obama what the menopause is. And she said, well, think about it like puberty in reverse. And if you understand the hormonal fluctuations that happen when you're a teenager, the mood swings, and that's essentially you coming into age where you're trying to balance out your hormones. And essentially the reverse happens when you reach that stage where, you know, you go through life and your reproductive years with a relatively controlled amount of estrogen and progesterone, and then as you get closer to the menopause, you go through the same process all over again. So I'm showing you this because I think it's important to understand what's happening to the menopause in time. One of the things that a lot of people don't really realize is that the age of menarche, which is the age at which the woman starts having her period, has significantly dropped from the 1800s until the recent times. Women or girls used to start their periods at the age of 17, 18, 16 maybe. And now it's closer, the average is closer to 12. And I know girls as young as 8 who start their periods. And so what does that mean for the menopause? So on average, women have around 450 to 480 periods in their lifetime. So this equates to about 37 to 40 years of having your periods. And that's quite regulated because obviously you have a certain ovarian reserve, you have a certain life. What we don't understand, and what we obviously it also adds to the lack of a focus or research in menopause is that graph actually equivalent to what happens to the menopause in time? And the assumption is yes. It means that the average age of the menopause is also decreasing. So women are reaching the menopause at an earlier age, and therefore the tools that are required to understand and help us cope with the potential symptoms of the menopause are much needed. So at Nepta Health, we provide a lot of evidence in the form of social media to try and improve access. And these are just some posts that we have on our social media, just essentially to get the conversation started, to get women to think about what's the menopause, what are the facts out there. And everything that we do is completely and utterly evidence-based. I'm very big on that. So to focus on HRT, hormone replacement therapy, I think a lot of women don't really realize that the length of the menopause can completely significantly differ between individual and individual. Some women will go through the menopause and very quickly that perimenopausal period goes away within 2 years. The average is 4 years, but there are women that continue to have some form of symptoms of the menopause up to 12 years after onset. Around 80% of women who go through the menopause experience some form of symptoms, and of course the extent and the severity of those symptoms changes between women. In the UK at least, only around 10% of menopausal women take HRT. So just to give you an idea that when we talk about HRT, we obviously talk about the various types of HRT. There are estrogen-only hormone replacement therapies. There are progesterone and estrogen combined therapy. So the combined pill is obviously estrogen and progesterone, and some women are prescribed estrogen-only pills. And these come in pills, creams, sprays, tablets, skin patches, vaginal creams, rings, suppositories. The actual mode of prescription and dose is usually governed by the OBGYN that the individual sees, and hopefully that the OBGYN provides a more personalized approach to each woman. And unfortunately, there's less personalization and more generalization when it comes to HRT, which is probably the reason why the majority of women are shy of taking HRT based on some of the facts around its side effects. So when you're thinking about the HRT, what are the benefits and what are the risks? So the benefits definitely outweigh the risks, and I'll explain that in a second. So the majority of women who take HRT definitely see improvement in the symptoms associated with the menopause: hot flushes, mood swings, night sweats, urinary incontinence, etc. There is evidence that taking HRT also reduces the progression of atherosclerosis, and obviously some of the benefits will depend on the type of estrogen or pill that you're taking and the mode of delivery. So, for example, women who see lower risk of stroke and deep venous thromboembolism is basically with women who take low dose transdermal estrogen versus the pill form. Now, the reason why the majority of women, when they were asked why they refuse to take HRT, is because of an established risk of an increase in breast cancer, which seems to only really show in women with longer term treatment of HRT. But this risk seems to disappear in the estrogen-only pill, so it's only the combined pill. And also it only increases in women above 51 years old. And it's important to, at this stage, also give you the facts that whilst that is an increased risk, it's nowhere close to the risk associated with the increase of breast cancer with obesity, for example. And one of the things that I like to mention when people discuss the links of obesity with cancer, and specifically with women, is, you know, one of the facts that I like to tell is the majority of estrogen in the woman's body is produced by the ovaries. So when ovaries stop functioning at the menopause, the levels of progesterone and estrogen drop. Estrogen needs to be counteracted by progesterone in order to basically modify the way that it works around the body. When there's no progesterone, women still continue to produce estrogen, but only through fat. So actually fat and fat cells are major producing engines of estrogen postmenopausally. And because there is no progesterone to counteract that estrogen, the increase in the level of estrogen is the reason why women are more predisposed to certain types of cancer. And that probably explains the immediate link with what hormone replacement therapy essentially does. So the NICE, which is the National Institute for Health and Care Excellence, recommends that there should be individualized approaches to all stages of the menopause and management of the menopause. Unfortunately, the majority of healthcare providers don't have exact guidelines as to what that personalized approach should be, nor do we actually base it on the basal level of hormone for each woman at that stage in time, and longitudinally to be able to actually maybe modify the dose so that women actually benefit from that rather than feel that they haven't had a very personalized or controlled approach. And I think that also giving women the right information and empowering them to understand more about their body and what they can do. And as Chiza mentioned, you know, having the right diet, doing the right things, exercising, all help in managing the symptoms. And it's important to understand that everybody's different, every individual is different, and so every approach should be different. But unfortunately, that's not the case, and hopefully this will change in the future. So that's what I have to say. If anyone has any questions, more than happy to take them now or after. I give you back the floor, Mary.
Okay, thank you. Yes, few questions, and one of them was ahead of this webinar. Let me start with the one here too. The first one is, can I have combined underarm implant contraception with HRT?
Can I have combined?
Underarm implant contraception.
With HRT?
Yeah.
Why is an individual having HRT if she's trying to stop getting pregnant?
Yeah.
Basically, what happens that sometimes not an implant specifically, IUD like a Mirena coil is advised as the progesterone handle of HRT. So they can have contraception in the perimenopause. So we are only talking about menopause. When you go to perimenopause, you have regular cycles. It may start like 3 or 4 years before you actually stop have your final period. So, and then if you have that Mirena coil, it has a lifespan of 5 years. It can continue when you are going through menopause and you're menopausal, and then you have the estrogen as a dermal patch or a cream or a ring. So then you're getting both estrogen and progesterone. So yes, sometimes it is advisable to have a Mirena coil or even contraception. Progesterone implant is also a type of progesterone. So when they're going through the perimenopause phase, not menopause, so they don't need contraception when they are in menopause, but they won't know till 1 year that they are in menopause, till they don't have a period for 1 year. So it is best to have, so we do advise to have contraception till they're sure that they're not menopausal, and have HRT according to their symptoms.
Okay, thank you so much. I hope that answers the question. Give us a thumb up if that answers your question. There's another one here. What is the role of the media in the uptake of HRT? Oh, I think he answers the question. They said thank you. Okay. What is the role of the media in the uptake of HRT?
It's everything really from my point of view. And the reason why individuals are hesitant and resistant to taking HRT is because of the exaggeration, in my opinion, of its negative effects. Everything needs to be presented in the correct way, but we know what the media does. We see it every day. We're seeing it today, in fact. They extract what they want, and I think that's a little bit of scaremongering has potentially maybe negatively affected the way that HRT is seen through individuals' eyes.
Yeah, I agree with Saba. Yeah, so media has to give the right information and give facts, give both sides of the story, not just one side of the story.
Yeah, that's very true, because there's a question here as well about, I heard about risk of breast cancer and blood clots. So it's about, having the balance, isn't it? And I had the same experience not long ago. I was sharing this with Saba when I was having a discussion with the doctor, and maybe because they know I'm a nurse or whatever, but he just started talking about the negative effect of HRT and why we've been doing this and we've been doing that. And I'm thinking, actually, patients should be given the choice to, the chance to make the choice, informed decision about, which way forward. So, yeah. And the media, we need to do something about that. Maybe we should start our own women's health media.
Yeah.
Because it's not just about menopause or perimenopause, it's about most things, really. The last question before we go on to our next speaker. Can tightness of throat be a symptom of menopause?
Pardon?
Tightness of throat, can it be a symptom?
It can, but it is mostly related to sometimes iron deficiency. So you have to be sure that you have your vitamins correct. And otherwise, maybe Chiza can say if it is related to the gut.
Tightness of throat?
Yes.
I haven't heard of that.
Yeah, so we do see in elderly women because of iron deficiency, especially when they are perimenopausal, they lose a lot of iron. So that's one of the reasons where you have, and that type of feeling can happen to anybody with iron deficiency. But in postmenopausal, it is slightly more common. Again, anxiety, mental mood changes, all these things can actually, it's a vicious cycle, create that anxiety and OCD about having tightness in the throat. That's my view. Yeah.
Yeah. Any other contributions? Okay, I think one more. This was ahead of the webinar as well. Can menopause affect someone who had uterus prolapse and the womb has been removed since the age of 44?
Yes,
Will the
can.
menopause problem still affect the person? Saba?
Yeah. So thank you for sharing that question in advance. The question is if that person's womb was also involving removal of the ovaries. And if the ovaries have been removed, then as I've mentioned in my chat, they no longer produce hormones, and therefore that can onset an early menopause, definitely.
Okay, so
there was another question from the same lady, Anita. It wasn't just the tightness of throat. It says muscle and joint pain, and that is
okay.
Yeah, that is definitely one of the symptoms of the menopause, having muscle and joint pain. So I would agree with that.
Okay, all right. Yeah. Oh my God, I've got 7 here. Okay, let's move on, and then we'll, go on to the next questions. Okay, let's have Dr. Nneka Nwankolo. Thank you for joining us.
Hello, and thank you. Can you hear me?
Yeah.
Okay, good. I'm sorry I missed the beginning of the talk. I have a short presentation, which I think, well, I'll try and share it. I always get this wrong, but yes, I've got it. And some of it, I'm afraid, will overlap a little bit with Saba's talk, but hopefully not too much. So I'm Nneka Nwankolo, and I'm an honorary consultant physician at Chelsea and Westminster Hospital, where I do a menopause clinic. I'm also an HIV physician, and I am a senior global medical director with an HIV pharmaceutical company called ViiV Healthcare. And I think you've probably talked a little bit about this, but so I'll go through it very quickly. So menopause, as I've heard you referring to, refers to the day a woman has her last period. And as you have said yourselves, a woman is said to be menopausal when she hasn't had a period for 12 months. So it's a retrospective diagnosis in a way. And it's usually a gradual process, but I think as Saba just said, it can also be sudden if a woman has her ovaries removed by surgery, or if she has treatments for various conditions such as cancer, that can stop the ovaries from functioning. And the periods usually gradually become more irregular and stop, but there can be a period called the perimenopause, which I've heard you refer to already, which is where hormone levels start to fall, but where a woman is still having regular periods. But the issue about the perimenopause is that very often people will have symptoms of the menopause, but because they're having regular periods, they don't recognize that they're menopausal. And this period, as I think has also been said, can go on for several years. So women can feel quite unwell with their menopausal symptoms, but not recognize that they're menopausal. Eventually the periods stop, which is called the menopause, and then you come to the period after your last period, which is called the postmenopause. The age of menopause varies geographically and by ethnic group. In the UK, the average age of menopause is 51. And it was interesting what Saba said about the age of menopause coming down. I think that the data conflicting about this. I mean, what we know is that sort of in the 19th century, well, earlier in the 17th, 18th century, when the life expectancy of a woman was generally very short, sort of in the 50s, a woman would become menopausal and then she would die. So there wasn't a long period of time for women to experience menopause symptoms. But as the life expectancy of women has increased, then the duration of menopause symptoms has also increased. Menopause has been seen to be slightly earlier in African, Asian, and Middle Eastern women compared to women of European descent. So maybe 3 to 4 to 5 years earlier. And there are influences of socioeconomics, genetics, and environmental influences on the age of menopause. And in fact, women of high socioeconomic status tend to have menopause later than women of lower socioeconomic status, and that's a really interesting view, or interesting finding. We know, and this is an article from the Telegraph a few years, 5 years ago, showing that a child born today is expected to live to be 100 by 2055. And because 40% of a woman's life is spent in menopause, i.e. in the postmenopausal period, that means that for some women, they may have a long time to be spent with menopausal symptoms, although the majority of that time will not be associated with symptoms. You talked about the frequency of symptoms, and Saba said this too, 80 to 85% of women in the menopause experience symptoms of some kind. Not everybody will experience severe symptoms, and not everybody will experience all symptoms, but most women will experience some symptoms, and these include hot flushes, aches and pains, as somebody asked a question about earlier, fogginess of thinking, which is a big problem for women who have high functioning jobs because they suddenly find that they can't work anymore. And many women, in fact, give up their careers because they have severe mental health symptoms with their menopause and are not aware of ways that they can help themselves. And there are something like 34 symptoms of menopause that have been described, although, as I said, not all women will experience all of them. And then there is this subject that most women feel very reticent to talk about, the sexual and genital symptoms that you get with the menopause. And the loss of estrogen that is associated with the menopause causes vaginal dryness, and that speaks to the question that the lady asked about whether you can have menopausal symptoms if you've had a hysterectomy. So if you had a hysterectomy and your ovaries have been removed, or if you had a hysterectomy for vaginal prolapse, then you can have all these symptoms of vaginal dryness, vaginal atrophy. So atrophy means when the vagina shrinks, and that makes sex painful. A loss of interest in sex, so loss of libido, problems with partners, because many women can't talk to their partners about menopause. They start to feel much less attractive, one, because their bodies have changed, because menopause is associated with changes in body shape. There tends to be more fat deposition around the abdomen. So women feel less attractive, but they also don't feel very much like having sex, and so their sex lives suffer, but they don't feel confident to talk to their partners or to other people about what they're going through. I think that it's probably been discussed why menopause happens. It's because of the reduction in the hormones that the ovaries produce, estrogen, progesterone, and also testosterone. And what's important to note is on this slide, on the right side of this slide, is you can see how estrogen levels fluctuate. So often when a woman thinks she might be menopausal, she might go to her GP to have her hormone levels checked, and the hormone levels come back normal. And so then she's told, actually, you can't be menopausal. But the reality is that if a blood test is taken at the time that the hormone levels are high, then a diagnosis of menopause isn't made. And so it's important to know that the diagnosis of menopause shouldn't be made based on blood tests. The diagnosis of menopause is based on a woman's age and the symptoms she's experiencing. The only time that a blood test is of value if women have symptoms that are not typical of the menopause, or if a woman is younger than the normal age of menopause. So in women who have menopause symptoms, for example, under the age of 45, then you might want to do a blood test just to confirm the diagnosis. But you wouldn't rely on just one blood test result. You would usually do a couple of blood tests by a period of time. So what can be done? Saba has talked very eloquently about what can be done. And what can be done related to the functions of estrogen? So estrogen is basically considered to be a lubricant. So first of all, it treats menopausal symptoms, but it has also been shown to be important in other aspects of people's health. So it protects against osteoporosis. The reason that women have strong bones before the menopause is related to estrogen. There is evidence that it protects against Alzheimer's disease, and estrogen is the reason that women before menopause have much lower rates of heart disease than men. After the menopause, rates of heart disease in women become the same and sometimes higher than rates of heart disease in men, and that's something that it's really important to know about. The reason that young women have more supple and less wrinkled skin than older women have, is because of estrogen. Estrogen is important for the health of the genital and reproductive tract, and menopausal women very often complain of urinary symptoms as well as the dry vaginas that I described earlier. And also estrogen is associated with reducing anxiety and depression, and the menopause is associated very strongly with mental ill health. Progesterone is another ovarian hormone, and the reason that women are given combined hormone replacement therapy with estrogen and progesterone is because if you give estrogen on its own, it causes the lining of the womb to build up and eventually cause an increased risk of womb cancer. Progesterone is given to stop that risk, or to remove that risk. So in women who have a uterus or a womb, it's really important when they have a hormone replacement therapy that they have both estrogen and progesterone. In a woman who's had a hysterectomy, she can have estrogen alone. She doesn't need to have progesterone. Progesterone also helps regulate bleeding, so progesterone is responsible for the way for us having our periods, for shedding the lining of the womb that is built up each month by estrogen. And natural forms of progesterone help to reduce anxiety and improve sleep, which is a big problem with menopausal women. A lot of women experiencing the menopause have problems sleeping. We don't talk very much about testosterone, but the ovaries also produce testosterone, what is considered to be the male hormone, but it's also a female hormone. And in fact, we produce more testosterone than estrogen. And testosterone is important in improving metabolism, in giving us energy, and also for our libido, for our sex drive. It helps joint pain, muscle aches, headaches, which are common in menopause, and also has a role in helping with depression. But some women do not have any genital symptoms at all, so they don't have any vaginal symptoms, even though they have hot flushes and other menopause symptoms. And some people don't have any of the other menopause symptoms, but have vaginal symptoms. And many women have a combination of both. And when you give HRT in the form of patches or gels or tablets, it very often doesn't do very much to help with genital symptoms. So it's important also to use creams and lubricants to help with genital symptoms, as well as vaginal estrogen. And vaginal estrogen usually comes in the forms of creams or vaginal tablets that you can insert, and they help to stimulate tissue regrowth to enable the vagina to go back towards the way it was before the menopause. It helps to improve lubrication, so to make sex more comfortable, improves the elasticity, the suppleness of the vagina, the vaginal wall, and it doesn't have the same risks that are associated with HRT, because the amount of estrogen that you absorb with vaginal estrogen is very tiny, equivalent to 2 tablets of an estrogen pill over the course of a year. So it's a really tiny amount of estrogen. So it's safe for many people who can't take estrogen for HRT for different reasons. So I think a take home from this, and this is my last slide, is that 40% of our life we spent in the menopause. And women should expect healthy lives, not just long lives. And so the right prescription of hormone replacement therapy started at the right time can bring immediate and long-term benefits. And the risks of HRT, which are actually very small in the vast majority of women, should be taken into account when you're considering the underlying health of the woman that you are speaking to. So thank you very much. And if there are questions, I will be happy to take them. Yeah.
Thank you very much for that. There's a question. This was ahead as well. And then there's another one that I'm going to mention. Okay, I took a screenshot. I turned 40 last week and have been having a foggy head, forgetting things, hot flushes, waking up in the middle of the night, soaking wet in my clothes, and a bit of a strange stomach. Could I be perimenopausal even if I'm taking the mini pill?
You could be perimenopausal. So at the age of 40, you're sort of at the younger end of the spectrum. But I mean, I heard when I first came into the call that someone asked a question about whether a 20-year-old could be menopausal. And I mean, we have a girl who is 19 who is menopausal, because people's ovaries can fail early. So yes, it's possible that you could be menopausal, perimenopausal. It's important that you see your GP just to have some tests to make sure that it's not something else. But certainly somebody who was older who had those symptoms, people would just assume that this was the menopause. So it's definitely possible. The thing about the mini pill is the mini pill only contains progesterone. It doesn't have any estrogen in it. So it's not like the combined pill, microgynon and so on. And so you can very easily have menopausal symptoms on the mini pill because it doesn't replace estrogen. So a woman who is taking the combined contraceptive pill with estrogen in it might not have menopause symptoms. And actually, in a woman who is perimenopausal, who has menopause symptoms but hasn't yet completed her menopause, so where there is still a risk of pregnancy, the combined contraceptive pill is something that could be considered. So yeah, the mini pill won't help menopausal symptoms.
Okay, thank you. Any other contributions or comments? Okay, the other question I'm going to answer myself, and it's in our survey actually. One of the questions in the survey is how many people would love to see menopause at work as a webinar or workshop, because that's our next step on menopause. And so that's the question, and I hope that answers you. So watch out for that. Stay with us. It will be in our newsletters, on our platforms, and things like that. Yes, it's very important because a vast number of women are in the workforce, and it's time that they begin, listening to us, meeting our needs, but holistically. Let me just use that word. Yeah. So thank you very much. Before I go to the next poll, let me bring in Dr. Kerr, who's going to be our next speaker.
Like I said, I didn't get slides because probably I'm not very well prepared. There's lockdown happening, so I was really busy with my clinic. That's not an excuse.
Yeah, but, it's really interesting that today, we have our speakers using slides. It's a choice actually. So yeah. I'm sure whichever way you deliver the presentation, we're going to have
Yeah, so basically I have some messages for women that they should actually start taking care of themselves, not in menopause, that is before menopause. So they start taking care of their diet, which is rich in omegas, vitamin D, iron, calcium, so that they don't start the process of osteoporosis. So the estrogen levels start falling even before they have stopped their periods. So they have to start taking care of their diet, their skin, their hair. So my expertise is in skin and hair and not HRT like Dr. Nenka. So I can only talk about what I would do with no knowledge of HRT. So if women don't want to take HRT, they can start non-HRT treatments are also available in the menopausal clinic. So there is all help available. Ask for help before we actually reach a stage where we have to work a lot, like prevention is better than cure. So skincare, Shiza said about skincare using sunscreen. There are treatments available like microneedling, radio frequency, which can be used to stimulate more collagen. So collagen goes down in menopause. So 30% of the collagen is lost in the first 5 years of menopause. 30%. Before we get into menopause, it is 1% every year. But 30% is lost, which is 6% every year. So there are creams available. So there are estrogen mimicking cream, which is not estrogen, but they work on estrogen receptors. So there's only one cream till now called Menopausal, which is available, which can actually prevent the breakdown of collagen. So the skin becomes dry, thin, and slack. So you can actually make the skin thick again by using creams which stimulate collagen, by using treatments, like I said, radio frequency microneedling, use sunscreen. So 80%, actually 80% of the aging of the skin happens because of the sun. And like being women, we know that we will lose more collagen than men. So men don't have over the mouth, wrinkles over the mouth, the perioral wrinkles, which women get. It's because we lose our collagen so quickly. We have less skin appendages. So we get more of the brunt of loss of estrogen. So we should start taking care of your skin from after the age of 20. That's when we start aging. So use sunscreen, use retinoids, use some collagen stimulating treatments. They are not bad. In ethnic skin, we have to take some care that we don't go for deep peels and skin treatments that damage the skin. But at the same time, there are loads of treatment available, and you can ask questions. You can contact Mary and she can put forward your questions if you have later on. That there are loads of treatments, especially vitamin D. Vitamin D is very important. And a lot of people are short of vitamin D in this country, especially because there is no no sunlight from almost like October to March. So take vitamin D supplements, omegas, take flax seeds, and like Chiza said, eat the rainbow. Yeah, because everybody said everything about what is menopause, how it happens, what it happens. So we need to prevent hair. The hair starts falling. So again, there are mainly two types of hair loss in women as we age. So they have not been able to say completely it's because of estrogen loss, but it actually increases when a woman reaches the menopause stage. So there's still some research going around to pinpoint that estrogen deficiency is causing hair loss or not. But there are treatments for hair fall prevention. So we are losing our periods, we are losing our skin, glow. We are getting lines and wrinkles, and we are losing hair. So there is so much psychological impact on women when we reach that menopausal stage. So for hair, you could take some shampoos which are good for hair loss. Um, uh, I believe in oiling the hair and putting some serums. So and also we can do needling of the hair, PRP. So we can take blood, spin it, and that same blood is injected into the hair, and we've got growth factors to prevent hair loss. So if women in menopause are facing hair loss, they can have treatments for the hair. So it's not about all HRT. It's also about having the look and the confidence. And if we have the confidence in our looks, when we look at ourselves in the mirror every day, I think that is very important. So invest on yourself, whether it is to do with your HRT or vaginal health. If you don't want estrogen, creams, you could go for non-estrogen lubricants. They are also available. So that also helps. And there has been research that they are equally good if people don't want to have estrogens. So find help for yourself. And people like Mary are creating a lot of awareness around menopause. And I think we all can do it together.
Yeah, thank you. Yeah, I love that. Yeah, we're all in it together. And, we need to come together and keep talking about it, keep raising the bar, keep, expanding the platform, and, so that as many women as possible will be empowered with facts scientific evidence and psychological evidence and support as well. Which brings me to the next question. How do we deal with the anxiety of going through menopause? I can see Neka smiling.
I try. Okay, I'll try. But I think the first thing I want to say is just to really agree with what Dr. Kaur said. I mean, I think it is important that women start looking after themselves long before the menopause. And I also think that it's not either or. You know, you should take care of your skin, take care of your diet. This is really, really crucial before the menopause happens. And there are some women who actually don't need hormone replacement therapy, and that's fine. But there are many who will benefit, and it shouldn't be either or, because you can do all the things that Dr. Kaur suggested, which are really important, and also have hormone replacement therapy. And you have the hormone replacement therapy for as long as you need it. Most women don't need it forever. But in order to, I mean, the number of women who, and I'm sorry because I've completely gone off topic, but the number of women I see who, I mean, I had a professor who came to my clinic and said, who didn't want to come because she'd heard all sorts of bad things about hormone replacement therapy and wondered why she'd been sent to me. But she said she wasn't functioning and she was about to give up her job. And this was a really high-powered economics professor. And so I said, well, you don't have anything to lose. Why don't you try? And she took it for 3 months and she came back and she said, you have changed my life. I didn't change her life. Replacing the hormones that her body would normally produce and had stopped producing changed her life. So for women who do need it, who really struggle, it's definitely a strategy. But there are other strategies as well. And women should try what they want to try, but not be afraid of trying something because of media scares or incorrect information. It's really important that women go out and seek the right information and then based on that decide what is right for them. Mary, can you please remind me what the question was?
Yes, I thought that would happen. How do we deal with the anxiety of going through menopause?
Yeah. I mean, do you know, I think that one of the ways that help, one of the things that helps to deal with this is forums like that, such as what Mary is showing, is producing, because women can see that they're not alone, that this is something that all women go through to some extent, and having the support of other women is really, really important. And one of the things that I have set up in my workplace is support for women who work in our organization. And so women come together in the times of COVID. They could come before COVID. They could come together face to face, but now we have webinars and online forums like Zoom, where people can share their experiences. And these are not forums where you necessarily get or give medical advice, but it's just about, oh, I have these symptoms and this is what I've done and this helps me, and just having women understand that they're not alone. But then there are also, you know, I guess formal treatments for anxiety and depression. But one thing that I have found is that very often women who have menopausal anxiety and depression are started on antidepressants. But the reason for anxiety and depression during the hormone that women aren't producing anymore. If a woman has an underactive thyroid, you wouldn't, and had low mood because of an underactive thyroid, you wouldn't give her an antidepressant to treat her underactive thyroid. You would replace her thyroid hormone. And so it's the same with hormone replacement therapy. If it turns out actually that the anxiety and depression are for some other reason, then yes, one should address that other reason. But then also it's not always about treatment. You know, psychotherapy, talking therapies, all of those things are also helpful. So this is, you know, this is not a situation where there is just one answer. There are many, many different answers. And I think, as Saba said, it's really important that women find the solution for them.
Thank you. Okay, Saba, since you've spoken so much about HRT as well, how long do we need the HRT? That's the next question.
I think, I mean, Nina also mentioned that as well, is every individual is different. And I think if you should be taking your HRT for as long as you think it's managing your symptoms. Some women take it for a few months and stop. Others take it for a few years and continue to take it. And it's just important to talk to your physician or talk to your BGYN and make sure that you're monitored on a regular basis to ensure that you're on the right regimen.
Okay, so I'd love to, I know you can all see the comments, but I'd love to read this one out. It says, I agree with all presenters. This is the sum of the answers. We need to support each other, share knowledge and experiences, and always acknowledge the individual journey. The theme tonight seems to be holistic and supportive. Loving this webinar. Thank you, Chiza, Saba, Bajit, and Neka, and myself. Thank you. Okay. Right. One more question, and this is from me actually. So what happens after menopause? The post-menopausal, I'm speaking to all women who are in the post-menopausal stage. Because if I look back as to when, I didn't know when it happened, but if I look back as to when I had an idea, I'm giving too much away now. And from what you've all said tonight about the time and, I mean, likely time, right, timeline, yeah, I may qualify. So let me speak on behalf of all women who are postmenopausal. Yeah, so what happens in that stage? What do we need to do in that stage?
Okay, shall I start?
Yes, please, thank you.
So the reason that the postmenopausal period is important is because this is the time when estrogen levels are pretty much gone. And this is the time when the risk of heart disease, the risk of osteoporosis, the risk of mental decline starts to become a problem. And so thinking about it, you know, there are many, many millions of women in the world who do not take hormone replacement therapy. And so not everybody will need hormone replacement therapy. But one of the reasons that women think about having hormone replacement therapy is when they understand that actually overall as a population, the risk of heart disease starts to increase because they are no longer protected by estrogen. And the thing is that you can't predict who is going to have a problem with their heart and who is not. I mean, often you can tell from your mother. So, you know, a lot of issues relating to menopause, you know, when you have a woman who experiences early menopause, she will often have a history in her family of early menopause. So her mother will often have had early menopause, or her sisters might have had early menopause. So if a mother, for example, had heart disease at a young age, then that might be a predictor of heart disease in her daughter if there isn't another cause like smoking or something like that. So to answer the question directly, it's possible that nothing happens in menopause, but it's also possible that you start to develop the medical conditions associated with aging and osteoporosis and so on. And the problem with those, so for example, osteoporosis refers to when the bones start to become less strong. And over time, because you don't have estrogen anymore, there is a risk of them breaking. And what happens is if a woman has osteoporosis and falls and fractures her hip, a fractured hip in older age is a big cause of hospitalization and death. And one of the things that Dr. Cole was talking about that is really important is about trying to keep your strength, trying to maintain your fitness and your health before the menopause, so that as you enter the menopause, you're still healthy. Because what happens when women lose estrogen is that their muscles become less strong. And so their muscles are not as good at supporting their bodies. So the risk of falls is greater and they become frail. Mm-hmm. So as women enter the menopause, it's really important that they improve their bone health by taking calcium, vitamin D, improve their muscle strength by doing weight-bearing exercise so that they don't become frail, because frailty is a big cause of death. And what you want to do as you enter the menopause is to reduce that. And taking estrogen is helpful, but you can do it without taking estrogen.
Okay, thank you. Thank you very much. So there's a question here. Is there an association between hypothyroid and menopause? As a nurse and midwife, there seems to be an occurrence of both.
So that's a good question, and there is not a definite correlation, because so the first thing to say is that all women will have menopause. So there is not a correlation in the sense that one of them causes the other. Early menopause may be associated with autoimmune conditions, and thyroid disease is often an autoimmune condition. So you might find that some people who have thyroid disease, either hyperthyroidism or hypothyroidism, so an overactive or an underactive thyroid, may have other autoimmune conditions. And an autoimmune condition that is associated with early menopause is ovarian insufficiency. So premature ovarian insufficiency, where in the same way that the thyroid malfunctions and either causes you to overproduce hormones or underproduce hormones, the ovaries can do the same. And so some women with autoimmune disease will have thyroid problems and ovarian problems and potentially have early menopause.
Okay, any more contributions? Saba, I saw you shaking your head.
No, completely agree. I just wrote an article about it, actually. You know, that there's a sort of an ongoing association between underactive or sluggish thyroids, obviously indirectly also affecting overall your hormones, regardless of whether or not you associate it with the menopause as a period of your life. It can present in perimenopausal symptoms or symptoms associated with the menopause, not necessarily because you're at that age, but actually because the thyroid is such an important organ in the regulation of your hormones overall, that it may have or present with menopausal symptoms as well.
Okay, I have a question for Chiza. And the question is on diet, okay? Especially with Africans and Black minority in that group, relating to non-Westernized diet. Let me use a big umbrella, non-Westernized diet. Yeah.
Oh, what's the question? Sorry.
Okay. I said I have a question about diet, nutrition from the non-Westernized point of view.
So do you mean what can you eat?
Yeah, what we can eat, what can help, or the modification,
So I think the first thing is to try and remove the refined processed foods or to replace them. I'm thinking, for example, of fufu, which is what is fufu? Fufu is like a
cassava. We have it in banana now.
A grain, but then people are becoming a lot more conscious, more health conscious, and they're replacing that now with banana, green banana, for example, a very good source of fiber. I think going back to a traditional diet in whatever culture really is a lot better than eating a Western diet, because typically a traditional diet has, a good source, lots of good sources of fiber. I think the problem really is associated with the refined processed nature of fast food. The fact that we're all very busy, we tend to look for the easy option. People are not cooking so much anymore. My sister and I went back to Nigeria recently, and there were fast food outlets everywhere.
Yeah.
They're a new thing. No one prepares fufu from scratch where they pound yam, for example. It's all highly processed. So it's the processed nature of the food that is problematic. It's trying to, I think, really incorporate lots of veggies into the diet. I gave a bit of a list. Green banana, yam, boiled yam. So sort of, I guess, coming away from your your highly refined diet and moving back to more of a traditional diet. And if you're looking for examples, it really depends on, what country, if I'm to give specifics. I mean, but I think it's really having the majority of the diet be plant-based.
Yeah. Okay. Yeah. Thank you. Oh my God, we are nearly coming to the end of it. And like I said, we need like a workshop, which will be maybe half a day or a full day. And we'll be happy to have all of you back. We give you enough notice. And then, because I'm seeing some nice comments and feedback here. Can menopause affect one's mental health?
Yes, it does. Yeah. And mostly it is because of estrogen deficiency. That's why HRT comes in, like Dr. Nanka said. And there are loads of things actually. I have a lot of list: anger, irritability, anxiety, tension, depression, sleep disturbance, loss of concentration, loss of self-confidence, loss of self-esteem, low mood, brain fog, going mad. These are all the things that can happen, apart from major depression that can also happen. But these are some things that people use to describe themselves. If you don't mind, Mary, I want to talk about that hypothyroid thing, because I suffer from hypothyroid and I also am menopausal now. So we generally, women, if I'm right, they gain weight in menopause. So their the bone mass and the muscle mass goes down because of estrogen deficiency. But if their weight is same as what they were before menopause, where has the weight come from? It's from visceral fat. So actually, menopausal women start developing more visceral fat, and hypothyroidism makes it more difficult for them to lose weight. So weight is also a big problem with women in menopause, and I'm struggling with it. I'm not like obese, but I'm slightly overweight. I need to lose around 5 kilos, but it's very difficult for me because of my underactive thyroid. And I know there are some alternative treatments which are not like traditional HRT available, where they increase your T3 levels, which is called BHRT, where you can lose weight. But I'm quite skeptical about it. I myself am not ready to take it, but I know it is there. So you have to be very active when you're menopausal and you have an underactive thyroid. Try to control your diet so that you don't develop more visceral fat.
Can I also just, sorry. I just wanted to make a comment. Have you finished? Sorry.
Yeah.
Oh, yeah. No, because I just wanted to make a comment about that. And I think what you said is very important. But actually, so the menopause does not cause weight gain. What causes weight gain is getting older. Older people get put on weight.
Yeah, I agree.
But the menopause causes a change in the distribution of fat.
Yes.
And causes women to start to deposit fat around their abdomen, including the visceral fat that you are talking about. And the problem with the fat that you develop around your abdomen is that it is very metabolically active. And so that kind of fat is associated with an increased risk of heart disease, which contributes to the risk of heart disease that we've been talking about. And when you have hypothyroidism and underactive thyroid, that makes it much harder, as you have said, Dr. Kerr, to lose weight, but also makes you gain weight because your metabolism slows down. So the two things together become, very difficult to manage. So what you're saying is very, very true. And it also then goes back to what you were saying before about how important it is to optimize your health before the menopause, so that you're less likely to start to put on weight. You've started already to become physically active. Because if you have always been physically active, then it's easy to continue to be physically active during the menopause. Whereas if you start for the very first time in the menopause to become active, I think it becomes harder to do.
So all those exercises and walking and stairs and everything is really good, and we should get into that habit before we are actually in menopause.
Okay, thank you so much, everyone. Do we have any more questions, comments? We're just like few minutes away now from closing. Oh, one question, sorry. Somebody wants suggestion for estrogen creams. Can you hear me?
Yeah. So there are many, but most estrogen creams are prescription only. So you would need to speak to your GP or menopause specialist about ones that are suitable for you. They're usually not available over the counter.
Okay. All right.
But they're the ones that you can get on prescription are all pretty similar.
Okay. All right. So I'm going to go around the speakers and ask you to give us your parting message or golden nugget. Saba, I'm starting with you.
I guess my golden nugget is a summary of everything that everyone is talking about. I think it's important for us to learn and be educated and embrace the fact that this is something that's going to happen to everyone. And it will happen to everyone in a different way. Don't be jealous that your sister has different symptoms than you do. You know, support each other. There are ways in which we can support each other. I think, you know, just ensuring that you look after yourself, look after number one, and, you know, keep exercising, eating the right things, always helps in conjunction with everything else that everyone's talking about. So thank you, Mary, also for organizing such a session.
Thank you. Bajit?
Yes, like everybody has said, absolutely the right things that I needed to hear, because I'm just entered menopause, and this has been very helpful. Thank you for inviting me, Mary. But I think for me, you can think of menopause also as a liberation. So people call it menopause, but I say it is the ending of menstruation. So it is not a pause, it is like a full stop, you know. So you don't have to think about your monthly periods coming again and again. So, and you're not alone. Half of the world's population is women, supposing arbitrarily. So 50% of the world's population will go into menopause. At the moment in UK, 13 million people are in menopause, and 1/3 of our life is to be spent in menopause for every woman. So let's not create and be anxious about it. Embrace it, and embrace it gracefully. And like, you know, 100-year-old women are running, they're doing marathons, and Iris is, you know, is a model. So let's start this new phase of life with full gist and full enthusiasm, and take this opportunity to do what we want to do. We've raised our children well, and we've moved out of, we've sort of established in our careers, and now give time to yourself, your health, your skin, your sexual health, because your vagina is also very important. Start with lubricants. Don't miss out on all the things that you were doing when you were not menopausal. Take care of yourself.
Thank you. Neka.
You know, I don't think I can add to what Saba and Bhavjit have said. I think what they have said is absolutely correct. I think talk to people about menopause, talk to your friends, let women speak about this, because for such a long time it has been a taboo, and it should not be a taboo. We should speak about this openly, freely, embrace it. If we're struggling with it, find ways within ourselves, between us and our friends, to address it, to make sure that our older age is as productive and wonderful as our younger age. Yeah, I think what you said about pause is true. It shouldn't be a pause. It should be the beginning. Truly, I really believe this. It is a liberation.
Yeah, thank you so much. Thank you everyone for joining. Thank you to our amazing speakers. And it's interesting, you know, how much fuss we make going through our period. Oh, it's coming again. Oh, what do I wear? Oh, what do I eat? And then, you know, it comes to an end and it's like, oh, what do I do? Oh, what do I wear? So, I mean, but the most important thing is, now we have the support, we have the education. I wish I had a platform like this 10 years ago. It would have been a different story. And that's why, you know, the onus, you know, on us all to keep going. Jesus had to leave us because
she hasn't slept.
Yeah, she joined us from Australia at 5 a.m. And yeah, I mean,
slept all night, she said. So
I left yeah, because I was sending her an email and I thought, oh my God, it's 3 a.m. out there, and I'm sure she saw that. So I'm greatly indebted to all of you for answering, honoring our invitation. Thank you very much. And I just want to say to our attendees, we appreciate your time with us as well. Like I said, you are a new, a special breed for us, because this time in 2016, on this day, we had our very first meeting and award ceremony. So we may have something for you later. I don't know yet. I have to consult, because sometimes when I'm excited, I do something and the advisory board will say, are you sure? But we have to do something. Also, next week we'll be talking about future of workplace, lessons learned from COVID-19. And the following week, actually, we have a back-to-back Wednesday and Thursday. The Wednesday will be cancer well-being, and the Thursday will be breast and cervical cancer. So please save the dates and join us. Also, at the end, there'll be a survey. There's another poll, but I won't bother you with that because all the answers, they've given us all the answers, both for the first poll and, much more, actually. We hope that through this, we've been able to, give enough information and scientific evidence and support and psychological evidence as well to help us all as we transition into this amazing phase of our lives as women, and also for those around us. So thank you so much once again to our speakers, our attendees. You've been amazing. We may not be able to see, but you can please give yourselves a round of applause because the interaction has been great. You actually kept us going. Thank you, everyone. Thank you.
Thank you for calling me Mary, and it's a good opportunity to meet such esteemed people with great knowledge, and I've made contacts.
Thank
Very
you.
nice meeting or e-meeting all of you.
Yeah. Yeah, don't worry, I'll bring you back. Yeah, this is Saba's second time, and I've told her that she's here to stay. You are all part of Zenith now, okay?
Yeah.
You have no choice.
Yeah, no, you've been conscripted.
No, it was an absolute pleasure meeting you all as well. And thank you to our participants.
Yeah. And Mary, thank you so much for organizing this.
Oh, you're most welcome. I thank you. It's made possible by all of us. Thank you. Thank you so much. Have a nice evening and see you all next week. Bye. Bye-bye. Thank you. Thanks.